Good afternoon. My name is Dr. Scott Landreth from Oregon Health and Science University. I'd like to welcome you to October's version of the Cardiothoracic section of the Academy of Online Education. Joining us this month is Dr. Andrew Stubenrock from Ochsner Medical Center. Before we get started, I would like to send a special thanks to Dr. Christina Foos from OHSU and Dr. Prasad Pons from the Mayo Clinic for helping us edit this month's publication. Researchers from the Changgung University in Taiwan compared the efficacy of subtracted coronary CT angiography with non-subtracted coronary CT angiography in patients with densely calcified coronary arteries and those with pre-existing coronary stents. The idea behind this trial originated from the observed poor diagnostic performance of coronary CT angiography in patients who have been stented or those who have severely calcified coronary artery disease secondary to extensive stroke artifact. Patients were screened for a multitude of coronary artery disease risk factors, including blood pressure, LDL, blood glucose, BMI, smoking history, and family history of coronary artery disease. Patients were enrolled into two different groups, those who were stented and those who are considered to have heavily calcified coronary arteries, defined as a calcium score of greater than 400, to undergo subtracted coronary CT angiography and non-subtracted coronary CT angiography prior to interventional coronary angiography for validation of results. All examinations were performed on a 320-row Toshiba CT scanner and were performed in a prospective manner with a breath hold during a single heartbeat. For the subtracted coronary CT angiogram, or CTA, a non-contrasted exam was first performed, followed by the contrasted portion. These data were then processed on an offline workstation, allowing for the creation of multiplanar reformats, maximum intensity projections, and for volume rendering. The proximal, middle, and distal segments of the right, left, and left circumflex coronary arteries were evaluated by subtraction and non-subtraction techniques for image quality. The presence of in-stent restenosis, or significant stenosis, defined as luminal narrowing greater than 50%. Any non-accessible segments were classified as in-stent restenosis, or having significant stenosis. 30 stented segments in 12 subjects and 202 calcified segments in 20 patients were evaluated for sensitivity, specificity, accuracy, positive predictive value, and negative predictive value were estimated for the performance of subtracted and non-subtracted CTAs in both of these groups, and findings were compared to findings on invasive coronary angiography. 3 out of the 30 of the stented segments and 32 out of the 202 segments of the calcified regions were determined to represent in-stent restenosis or significant stenoses. Subtracted CTA proved statistically superior to the non-subtracted exam in specificity, accuracy, and PPV for the stented and heavily calcified groups, with an impressive specificity of 100% and 97.6%, compared to 55.6% and 76.5% respectively. Subtracted coronary CTA also proved to produce higher quality images than non-subtracted CTA, achieving a score of 3.27 versus 2.59 with a p-value of less than 0.001. Other statistically significant differences included the highest total calcium score between stented groups, which was 453.9, and the heavily calcified group, which was 2,023, with a p-value of less than 0.001. The heavily calcified group also incidentally exhibited an increased systolic blood when compared to their stented compatriots. These results suggest that subtracted coronary CTA generates higher quality images that allows for the superior specificity, positive predictive value, and accuracy in diagnosing in-stent restenosis in coronary artery disease in patients with pre-existing stents or those who have severely calcified coronary arteries. Subtracted coronary CTA has some notable drawbacks, including increased radiation dose to the patient compared to standard dual energy coronary CTAs, and the need for a high level of patient cooperation to aid in image acquisition. Researchers from Seoul, South Korea, sought to evaluate the efficacy of a deep learning-based automatic detection algorithm in helping to identify subtle malignancies on chest radiographs. The authors combed through 2,897 radiographs taken between January 2010 and December 2014 to identify 118 patients who had subtle visible lung cancers on previous chest radiographs. Data was then expanded to include 147 radiographs in order to include patients' prior radiographs if the nodules had been missed on prior studies. A healthy control group of 234 patients was randomly selected from 145,387 chest radiographs that had been interpreted as having no active lesion or as within normal limits from the same time period. The 147 studies with nodules were combined with the 234 healthy control studies for a total of 381 studies. This group was then randomly split into equal cohorts labeled A, B, C, and D, containing either 95 or 96 chest radiographs, since the total number of studies was odd. 6 chest radiologists and 3 radiology residents were then asked to read through each cohort of studies twice, once with the assistance of the deep learning-based automatic detection algorithm and once without it, with a 4-week washout period in between. The deep learning-based automatic detection algorithm used as a commercially available convoluted neural network, which was created by Lunit, a South Korean company, which was trained on 43,292 chest radiographs with 25 layers and 8 residual connections. The algorithm works by generating a color map over the radiograph that correlates to a lesion by using a 15% activation value, and then generating a probability value between 0 and 100%. The radiologists were tasked with replicating this function by identifying subtle areas of concern, placing a region of interest over it, and assigning a confidence value of 0 to 100%, then determining whether or not to recommend a follow-up CT scan. Operators' performance with and without the algorithm was assessed by generating an alternative free response receiver operating characteristic curve using commercially available software. Operators were also assessed on their relative sensitivity and specificity, both with and without the aid of the algorithm. The use of the deep learning-based automatic detection algorithm resulted in significantly increased sensitivity and specificity for both chest radiologists and radiology residents. Interestingly, this improved performance was greatest among the radiology residents when compared to the attending radiologists. Most importantly, more subtle lesions were identified with the use of the algorithm than without it, and the average reading time decreased, although this was not statistically significant. There are multiple problematic areas in this study, mainly the relatively small sample size with a fairly large number of true positive films, which is likely to increase the reader's overall specificity and which does not accurately reflect clinical practice. Also, since the observers are reading each film twice, recall bias may have an untoward effect on results, even with a 4-week washout period. This article seems to reflect what others have suggested, in that the use of deep learning-based algorithms may augment radiologists' ability to detect subtle cancerous lesions on chest radiograph, an area that is currently responsible for a large swath of medical legal ability claims. Researchers from the University Hospital Bonn in Germany designed a prospective trial to evaluate the association of liver cirrhosis and myocardial inflammation and fibrosis. Cirrhotic cardiomyopathy has been shown to occur frequently in a cirrhotic patient population and represents a significant source of morbidity and mortality in a fragile patient population. This prospective study utilized multiparametric cardiac and hepatic MRI in 42 patients with known cirrhosis and portal hypertension without a significant cardiac history, and 18 healthy controls who had been referred for MRI to rule out structural causes of heart disease and nonspecific cardiac symptoms. These 60 patients underwent combined cardiac and hepatic MRI exams performed using a single scan via a 1.5 Tesla whole-body MRI. The cardiac portion of the MRI was EKG gated for steady-state phase precession cine images. Myocardial T1 and T2 relaxation times were obtained via cardiac mapping, and hematocrit-corrected extracellular volume, otherwise known as ECV, was determined using pre- and post-contrast T1 images. Late gadolinium enhancement, referred hereafter as LGE, was assessed qualitatively by consensus agreement between 2 different radiologists. Hepatic images were evaluated by 1 radiologist blinded to the cardiac findings. T1 and T2 relaxation times and ECV of the liver were obtained. Liver stiffness was estimated using hepatic elastography. During statistical analysis, the 42 cirrhotic patients were stratified by Child's Pew score into Class A, Class B, and Class C. No differences in left ventricular ejection fraction or left ventricular end-diastolic volume were observed between groups. The cirrhotic group did exhibit statistically significant increases in heart rate and cardiac indices. Myocardial T1 relaxation times, ECV, and the presence of late gadolinium enhancement were all significantly elevated in the cirrhotic group compared to the healthy control group. These effects were found to be related to the patient's Child-Pugh score, with patients who have more severe liver disease exhibiting increased T1 relaxation times, ECV, and LGE, suggesting an association between the grade of one's liver disease and the extent of myocardial fibrosis and inflammation. The longitudinal strain in cirrhotic patients was decreased in cirrhotic patient population, suggesting a subclinical component of systolic dysfunction in this group. MR elastography-based stiffness was the only reliable variable to be independently associated with late gadolinium enhancement, increased myocardial T1 relaxation time, and ECV. Researchers found that by implementing a cutoff of 9.2 kilopascals in liver stiffness, a sensitivity of 77.3% and a specificity of 75% was achieved for detecting the presence of non-ischemic late gadolinium enhancement. This is clinically relevant since late gadolinium enhancement can be used as a marker for increased adverse cardiovascular outcomes in patients with non-ischemic cardiomyopathy and all-cause mortality. It is therefore suggested that patients with hepatic fibrosis may benefit clinically from closer cardiac follow-up. This study nicely demonstrates how the function of the heart and the liver are intimately entwined, and that as liver function is impaired, serious cardiac dysfunction follows. There were several limitations to this study, mainly that the radiologists were not entirely blinded from the hepatic findings, since part of the liver parenchyma is in view during short-axis evaluation of the heart. Other limitations include the study sample size and the absence of rad path correlation of the presence of liver fibrosis.
Hello, my name is Dr. Andrew Steubenrock. I'm a second-year radiology resident at the Oshma Clinic Foundation in New Orleans, Louisiana, and I will be talking about a few different articles of the cardiothoracic literature. Our first article is titled Calcium Scoring, a Personalized Probability Assessment Predicts the Need for Additional or Alternative Testing to Coronary CT Angiography. This is an article from the recent Journal of the European Radiology. Researchers from MTSC Cardiovascular Imaging Research Group from Semmelweis University in Hungary wanted to evaluate the usefulness of the calcium score in combination with anthropometrics and risk factors for predicting if alternative diagnostic testing would be beneficial if coronary CTA showed non-diagnostic images or insignificant stenosis. 4,120 patients were retrospectively reviewed. 276 of these patients had a non-diagnostic CTA in at least one coronary segment, and 1,073 patients had at least a 50% stenosis. The researchers used multiple models to test their hypothesis. The first model used BMI and heart rate and presence of arrhythmia at presentation. Model 2 included the components of Model 1 and included age, gender, and type of angina at presentation. And Model 3 included the components of Model 2 and included the coronary artery calcium score as well. They show with the first model that there is no significant diagnostic accuracy when using that model in combination with coronary artery CTA. But they did show that when using Model 2, which had the components of Model 1 as well as age, gender, and type of angina at presentation, that discriminatory power improved with an area under the curve of 0.72 and a p-value of 0.001. And additionally, when adding the coronary artery calcium score, which was Model 3 plus the Model 2 components, that discriminatory power improved yet again with an area under the curve of 0.84 and a p-value of 0.001. They also calculated odds ratios for multiple different factors, and they showed that if there's a type of arrhythmia at presentation, odds ratio was 2.12 for increased odds of downstream testing. Atypical angina was increased by 1.29, and typical angina was associated with 1.64. Additionally, they compared the results of all three models with the non-diagnostic CTA image quality, and they showed that there was no significant model that showed increased discriminatory power for the need for further testing. In patients with significant coronary obstruction visualized on CTA, Model 1 was also not shown to not have significant discriminatory power. However, when compared with Model 2 and additionally Model 3, that diagnostic power did improve and that further alternative testing would be necessary. The area under the curve for Model 2 was 0.74 and area under the curve for Model 3 was 0.87 with a p-value of 0.001 for both. Additionally, the researchers wanted to evaluate the classical different grades of calcium scores. For reference, that's 1 to 10, 11 to 100, 101 to 400, 401 to 1000, and greater than 1000, with a relation into the type of angina presentation, heart rate, and arrhythmia. They found that due to the importance of each of these factors in regards to cardiac risk, that researchers discovered that there was no single cutoff value for coronary artery calcium score that would predict the need for further cardiac diagnostic testing. However, through their research, they were able to develop tables that incorporated each factor, which allows for guidance to determine if further downstream diagnostic testing is needed. The study had several limitations, like most studies do. First, the study was a retrospective study, and the data was acquired from a single center and a single vendor. Additionally, fractional flow reserve was not incorporated, and the results of the downstream testing were not part of the study design. However, overall, the researchers did conclude that routine evaluation of coronary artery calcium score before coronary artery CTA may be advised, as it helps identify patients in which further evaluation will be necessary. Our next study is titled Observer Performance for Detection of Pulmonary Nodules at Chest CT over a Large Range of Radiation Dose Levels. And this was a recent article from the Radiology Journal. Researchers at the Mayo Clinic wanted to investigate the role of low-dose radiation chest CT with that of routine-dose chest CT to evaluate indeterminate pulmonary nodules of 5 millimeters or greater, with indeterminate nodules being defined as no definite benign features. This was a retrospective case control study involving 83 patients that underwent routine-dose chest CT for pulmonary nodule evaluation. The routine scans were acquired via single X-ray source at 120 kilovolts and automatic exposure control setting of 70 quality reference milliamperes, a 0.5 second rotation time, and 128 by 0.6 millimeter detector configuration. Subsequently, the scans underwent filtered back projection or iterative reconstruction to produce lower dose data sets using the original acquisition data. Overall, the researchers found that per patient and per nodule sensitivity drops with declining radiation dose. However, specificity remains virtually unchanged despite a 25-fold difference in quality reference milliamperes between the routine dose and the re-engineered low radiation dose, and this ranged from 70 quality reference milliamperes to 2.5 quality reference milliamperes. Additionally, it was shown that sensitivity for subsolid nodules is significantly decreased for all dose configurations less than 10 quality reference milliamperes, p-value is 0.05. But also, multiple issues were raised during evaluation of the decreasing radiation dose scans, including lower overall diagnostic image quality, greater image noise, and worsening sharpness. However, the results showed that radiation dose could be reduced by 1/7 of a routine chest CT and 1/3 of the low-dose screening CTs that we currently are using for our annual cancer screening, while still yielding non-inferior performance for indeterminate pulmonary nodules. Alternatively, part solid and subsolid nodules were shown to have decreased detection at radiation dose levels below that of the standard low-dose screening CT. Of note, the comparison of iterative reconstruction to filtered back projection showed that iterative reconstruction has subjectively better image quality for lower doses. However, the data did show that there was no difference in observer performance, although further research is needed to be completed. Further decreasing radiation dose for annual screening should provide long-term benefit. The limitations of the study: it was a retrospective case control study designed with limited readers who did not examine the non-axial multiplanar reformats, as most current radiologists will do. And also another limitation was the extrapolation from subspecialized radiologists to general practitioners is also a potential limitation, as annual CT screening cancer exams are generally read by a wide range of radiologists. Additionally, they did find that the cohort had a greater proportion of subsolid nodules, which may not reflect a true population prevalence. Our final article is titled CT-Based Biomarkers for Prediction of Chronic Thromboembolic Pulmonary Hypertension After an Acute Pulmonary Embolic Event. This is from an article from the recent iteration of the American Journal of Roentgenology in October. Researchers from the Cleveland Clinic, Leiden University in the Netherlands, and Arusian University in Thailand investigated the role of CT-based markers and their predictive value for developing chronic thromboembolic pulmonary hypertension after an acute pulmonary embolism. Chronic thromboembolic pulmonary hypertension is categorized as Group 4 disorders in the updated clinical classification of pulmonary hypertension. Chronic thromboembolic pulmonary hypertension is a treatable form of pulmonary hypertension, typically with pulmonary thromboendarterectomy. However, early diagnosis is imperative to success in treatment, as delay worsens prognosis and perioperative mortality rate. This study was performed retrospectively to evaluate patients that had developed chronic thromboembolic pulmonary hypertension and re-examined initial presenting chest CT to assess if markers could be determined that would predict eventual chronic thromboembolic pulmonary hypertension development. Exclusion criteria included patients with signs of chronic PE at baseline or other significant lung disease which could contribute to development of pulmonary hypertension. Then, subjective grading of thrombus was examined in the main pulmonary artery, left and right main pulmonary arteries, as well as all 5 interlobar branches. Branches were graded as no obstruction, incomplete obstruction, and complete obstruction. Additional markers evaluated included the Walsh score, which is a quantitative measurement of abnormalities in the segmental pulmonary artery, right ventricular diameter, left ventricular diameter, right ventricular diameter to left ventricular diameter ratio, right atrial diameter, pulmonary artery diameter, evidence of right heart thrombus, evidence of pericardial effusion, evidence of lung infarction, and evidence of mosaic attenuation. Univariable analysis of these markers was then performed, and multiple factors were shown to increase the probability of chronic thromboembolic pulmonary hypertension development. Occlusive central or lobar clot on initial imaging, the Walsh score, evidence of lung infarction, and mosaic attenuation were all found to be associated with future chronic thromboembolic pulmonary hypertension development, with a p-value of 0.001. Pericardial effusion was also found to be associated with a p-value of 0.017. Additionally, other signs that they investigated, such as the right ventricle to left ventricle diameter ratio, diameter of the pulmonary artery or the right atrium, right heart thrombus, had no association with development of future chronic thromboembolic pulmonary hypertension after acute PE. As with all studies, the limitations of this study include a retrospective design and possible selection bias due to exclusion of certain patients from the sample. The patients included in this study were from the PE response team that had a submassive or massive pulmonary embolism, which could result in potential bias. Additionally, ventilation perfusion scans or additional functional tests were not evaluated that could have better sensitivity to evaluate perfusion defects as compared to CT. But overall, the study does show that certain CT-based biomarkers can play an important role in identifying patients at higher risk for development of chronic thromboembolic pulmonary hypertension after an acute PE. Well, thank you for listening. This has been a presentation of the American Academy of Online Radiology Education.